Welcome to the Health Deli, your local stop for a fresh take on community health topics. Come on in, grab a number, and let the guys behind the counter, Mark, Ben, and Mike, tell you about today's specials.
Good day and welcome back to the deli. I'm here today with Mark, back in the meat section.
Hello, yep.
How's your meat today?
Not bad. Running a special on bacon.
Yeah, you would do that to me, wouldn't you?
Mm-hmm.
With the whole vertigo.
You can't have bacon, can you?
No, I can't have
That's
bacon.
why we were running a special on it. We haven't been selling nearly as much since you quit eating it.
Hey, Andrew, are you doing something nice back there in the beverages?
Yeah. We have no salt beverages.
That's all you got for us. I was hoping for a little bit more back there.
Is that water?
yeah, basically. No, and beer.
Oh, sure.
I found out this morning that beer doesn't have salt.
Really?
Except maybe a Goza. But anyway, that's a discussion for another time. Today, we have a special guest. I was trying to figure out if that was the right word.
I think so.
Esteemed. I'm not talking about
guest. Oh, well,
so,
never mind that.
So we've had a lot of discussion about drug pricing and the mystery behind all the curtain, like the Wizard of Oz type of feel. So it kept coming up that maybe we should ask a health economist about this. And unfortunately, the only health economist I know, I think, is the gentleman sitting over here who is my brother. So we had to invite him on. Say hi, Don.
Hi, Don.
Yeah.
Wait, the only health economist you know, or the only one you could afford?
Yeah, pretty much. Okay. The only one that was willing to come and sit in a room with me, get this close and stuff like that. So, yeah. Well, before we let him talk anymore, Mark, why don't you tell us what's going on?
Well, I'm working on a couple things. One is an episode on aging. Kind of reverse.
Why do you look at me when you say stuff like that?
Well, I mean, it's quite obvious. So we want to learn how you've been able to live as long as you have, to your ripe old age. But
it's the hate. The hate keeps me warm.
Just looking at some factors that can influence or kind of help someone to live past 100 years old. So like you. And then I'm working on another episode about caffeine. So friend or foe.
Got it. Double-edged sword, if it were.
Maybe we'll find out.
Okay. All right. Well, me, on the other hand, I still want to do an episode on outpatient antibiotic use and how healthy living can help reduce your need for antibiotics. Also, want to build on that past episode that we've done in each of the past two seasons, asking questions from the listeners, where we asked the kids the first season, and then we asked college students last year. Now I want to ask my peers, the old people.
Go to a nursing home?
Sure. Why am I here? I keep asking myself that. Andrew, is there anything that you want from coming up in this season besides getting rid of some of the people that are here right now?
Well, I've just been working on the production value of the Health Deli. So if you are not watching on video, check us out on Spotify. And I've been thinking about putting us on YouTube.
Oh, nice. YouTube.
So for this episode, we've upped our game a little bit here at the Health Deli Studios. We have a camera that looks like it's on a train track now that moves around. So hopefully the viewers, not just the listeners, the viewers will appreciate that, upping our production quality.
Yeah, there you go. And for those of you that are viewing, you probably noticed the really swanky swag Health Deli merch that we got going on here. We've threw the logo down on some stuff, and I've actually even had people ask if they could buy these things. So
yeah,
I don't know if they've just got a lot of expendable income or whatnot. But
I'll sell them your coffee mug.
Pre-used.
Yeah. Well, you're in the sundries, so this would be your department, right?
Right.
Yeah.
Okay. Well, so we'll work on that. We'll work on possibly getting some swag out there. We'll give that to Andrew over there. It seems like something he would do. But let's get back to business, as they say. And Don, besides having the honor of being my younger brother, even though
much younger.
Well, that's not what most people believe.
And smarter.
Better looking.
And better looking.
It's still not what I hear from most people. Tell us a little bit about yourself and why you're qualified to be here.
Again, your brother, the only person who would turn up. So it's, qualified. So I am Senior Associate Dean for Academic Affairs, University of Nebraska College of Pharmacy, but I'm not a pharmacist. I was the one who listened to mom and dad and So yeah, my background, pharmaceutical socioeconomics is my PhD from the university.
What is that? Pharmaceutical socioeconomics. That sounds just made up.
Let me break it down into words you can understand. Pharmacy, drugs, socio, people, economics, money. So kind of the intersection of drugs, people, and money.
My 3 favorite things.
Yeah.
Yeah.
I thought I was one of your favorite things.
No.
You fit into one of those 3, actually.
All right. So your background and training is looking at health systems and how, drugs and people interact and blah, 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 and stuff like that. So, and you were actually able to make a career out of this.
Making a go. Maybe not there yet, but I mean,
okay.
Yeah, so far so good.
So tell us some of the things that you've done in the past. What have you looked at?
Yeah, I mean, so obviously looking at some drug specific pricing, bargaining power, how pharmacies are able to differentiate pricing. That was actually my dissertation. My wife reminded me of that before I left. More recently, it's probably been a lot around health services and the role of the pharmacist. It's, as you mentioned, there is no end to topics because at the end of the day, pharmacy is big business. It is money. It is, healthcare. So trying to look at how we can take a finite resource of money and get the best value for it, right? If we had unlimited resources, we wouldn't be having this conversation today.
Okay. And so that, I guess, help me out with this because I've got just a very rudimentary understanding of economics in general. And pretty much all I remember is supply and demand. If, somebody's, got a lot of supply, prices go down. If there's high demand, prices go up. It doesn't always seem the way healthcare economics work. So why is there this disconnect? Or am I just missing the boat?
Yes, on you missing the boat, obviously. But I mean, it's complicated, right? At some level, yes. Supply and demand, the perfect competition market equilibrium exists in healthcare. But if you think about it, there's a number of assumptions. One, there's no outside interference. Well, I mean, immediately, if we think about healthcare, think about the role of the government, think about the role of third parties and insurers. We also assume people understand, like, what the value is. If you eat a piece of pizza, it makes you, hey, I'm not hungry anymore. But think about a lot of pharmacy, a lot of healthcare. The value isn't immediately clear to the patient, to the consumer. And so because of that, they don't know how to value.
Okay.
Right. So that's the role of the learned intermediary, the physician or the pharmacist. I mean, so there are just so many things that, let's go to patent protection, right? It limits the ability of people to enter and exit the market. All of those things impact prices. And so, at a very simple level, yes, the market for pharmaceuticals or healthcare is based or founded in economic principles, but we pervert it at every turn, right?
So let's look. I have a question just about drug pricing.
Sure.
So what kind of goes into that? Now I know it's not just it costs X amount of dollars to source the ingredient and make it into a tablet and get it to the consumer. What else? What else goes in there?
Right. I mean, the production cost or the manufacturing cost of most pharmaceuticals, small molecules, is nil. Right. I mean, it
barely factors
pennies. Right. Yeah. So what goes into it? First and foremost, if you talk to a manufacturer, a drug company, they're going to say, well, it's that investment in developing the drug. Right. Think about, and again, that's that government intervention of all the steps and the years it takes to bring a product to market. Millions and millions of dollars. Well, and then what they'll also say is, remember now, about 1 in 10,000 new molecules actually makes it to market.
Right.
So you're paying for a lot of failure every time you
I'm used to paying for failure. I mean,
why are you looking at me?
So it's that development cost. Some people would say that's marketing costs. That goes into it.
Now I've heard that medications in the United States are more expensive than other countries, but for this exact same med. So let's say a drug manufacturer makes some kind of new medication here in the United States, and in the United States, it's $1,000 a month. But in maybe Canada or Mexico, it's $600 a month. Why is that?
So for new meds, absolutely right. Part of that is because we are paying for the development.
Sure.
We are subsidizing
being the people in the United States.
Yeah, we are subsidizing that. Now, the other thing is you've got a single payer system in most of those countries, and they're negotiating.
So what do you mean a single payer system? I mean,
so if you go up to Ontario, the province,
beautiful,
old Canada, the government is the primary payer, right? So they are saying to the drug company, this is the cost, this is the price we will pay for this drug. And if you want to be in Canada, that's the price. Obviously that's not how we do things in the US. We have multiple payers. We have cash paying customers. Certainly we could talk about health policy. So for that reason, we end up paying more in subsidizing the price.
That seems wrong. Just because the government doesn't have the ability to say you're on our formulary, not on our formulary, or then the rest of us all get hosed.
Well,
I thought free market economies were supposed to level prices.
So again, remember you're talking about a drugs on patent, right?
Okay.
So it's single source brand name drugs. If we want to talk about generics, they're actually less expensive in the U.S. many times than in other countries. But for those patent protected drugs, it's just they have a monopoly, right? You remember the board game?
Oh yeah, the dude with the monocle.
These guys. I mean, they are boardwalk, right? These are the most expensive. They get to set the price because.
And Mark, you live on Baltic Avenue, I believe. I think that was the purple one, right?
No, I'm. That's a low rent district.
Yeah,
I'm more Park Place. I'm Park Place.
No, you're not. you're definitely not. And you have to be the thimble.
Okay. I always picked the car. I don't know. Thought that was the fastest.
No, you're more of a thimble. I think I'm the dog.
Now you talk about monopoly, though. I mean, the FTC, though, they don't allow monopolies, right? So are they ever involved in this kind of process? I know, I can't remember. I should have looked this up before, but there was the Pharma Bro.
Prepping for us, for a podcast.
I should have.
Yeah.
But do you remember Pharma Bro, they called him, and he bought the rights to that generic med and then jacked the price way up. So, I mean, there has to be some kind of oversight on pricing. I don't know what that would be, but.
Surprisingly little.
Okay.
I mean, right. Where the FTC would get involved is if there was one.
What does FTC stand
Federal
for?
Trade Commission.
Okay, so it has nothing to do with fair trade.
No. I mean, no. This isn't coffee, right?
Okay.
If there was one drug company and buying everything up, maybe. But
Sure.
the way they look at it is, you can develop another statin, you can develop another. So there can be competition, but drug companies go out of their way to find those opportunities. And this is where we step back and say, as a free market economist, good for them, right? I mean, they're seeing an opportunity and they're returning value.
And without those companies, there is no more development. So they got to have a profit. They have to have investors. They need to take the risks on those other. What'd you say, 900 or 9,999, whatever,
right?
Molecules that fail.
Yeah, I mean, think about it. Do you want to go back to the 1980s when Mike was in his 30s and
60s,
70s? Yeah. And there were a handful of drugs that of limited clinical use and value.
Well, there were a whole lot of leeches.
Right.
The leeches were great.
They're expensive though, right? If you don't have your own leech farm,
had to keep them alive.
Mm-hmm.
So all of the innovation comes at a cost, and they're.
So do you think if the United States went to a different payer system or allowed Medicare to more aggressively negotiate drug pricing, do you think that would stifle innovation then? I know that's what the drug companies are going to say, but do you think there'd still be a big enough carrot there to innovate and develop new meds?
I think there would be. I mean, certainly, we all work at colleges of pharmacy. We are producing new pharmaceutical scientists. There are people who are interested in this. The NIH funds a lot of this entry-level research or basic science research. So I do think there would be. I think what you would find is it's that last mile of going from a potentially marketable drug and bringing it to market and getting it into wide use. I think that's where you would see probably some stifling of innovation. Would that be bad? I mean, look, there are.
Well, I mean, seriously, one of the things you said is, oh, you just go make another statin. There's your competition. Do we really need 42 different statins for cholesterol? Or do we just use the most recent one because it's got to be the best? Or
Well, there's two ways to think about that. Does it offer a clinical benefit? Probably not. But with the plethora of statins that are available, I mean, some pharmacies give them away because they're so inexpensive, which, reduces cost. So I get both of the arguments there is that, yeah, it probably offers no clinical benefit to have another Me Too drug. But if it lowers costs, then it increases accessibility.
I mean,
So-
nobody is developing a new statin to be a low-cost alternative, right? They're going to come in and say, well, you can use it in this new clinical indication, or some way we can charge more for it, or it's longer.
It's a little bit better.
It lasts longer, or you take it once a year, or whatever it is. Nobody's going to innovate as a low-cost leader.
Mm-hmm.
But it does ultimately, right? There are more options. There is competition, which is, back to your original question, that gets us closer to kind of true economics, right? If there are more options, if there are more drugs out there, then ultimately prices go down. But on the flip side, and we see this, and you guys know this, when there's no real profit margin and fewer people start making, that's when we end up with shortages, right? If there aren't 40 companies making amoxicillin and there's one, and that company has a problem, now all of a sudden a drug that costs pennies costs,
and we'll talk about that a little later in the episode, because that is something I really want to talk about, are all these drug shortages and why it does it seem like we never used to hear about these, and now everything is shortage. So we'll park that one there for a minute, but let's get back to the drug pricing on this. How is that determined? And again, I've also heard that there can be multiple prices for a single medication, depending on whether you're with insurance A or B, or paying cash. I mean, how can there be different prices that people are paying for the same thing?
Well, and I think that when most people talk about drug price, that's what they're talking about, is this lack of transparency. We go buy gas, and go down the street and you see that, $3.09 or whatever, and maybe it's a little different across town. But you're absolutely right. We've introduced all of these third parties, the PBMs, the managed care companies.
Okay, PBM, that's not like a PB&J.
Oh, that'd be great. No, pharmacy benefit manager.
That sounds cool, because they're managing my benefits.
Right. Well, I mean, that's their job. So if you think about pharmacy and drugs and getting it to people, if somebody else will pay for it, that's good, right? I mean, that's better than you having to pay for it. So, having that insurance, but at least historically, it was carved out of your regular health insurance because it was a lot of low dollar transactions. So it was very transactional. You're not working with hospitals, you're working with pharmacies, all of those things. And so their role is to come in and get a better deal than the patient would pay without it. Right. So if you've got insurance through your employer, and I'm a PBM, and I'm going to come to you and say, hey, you should partner with me, I have to show some benefit. And
so kind of like a negotiator on behalf of the patient. So
the PBM will then go to both the pharmacy, but also to the manufacturer and say, hey, sweeten the deal for me. I'm going to pay you pharmacy less, or manufacturer, give me a rebate, give me a kickback, give me some, so that I can.
So they can do that?
Yes.
That's legal?
Yeah. I mean, that's, and I think, yes. I mean, does it happen in other industries? Probably.
I mean, part of it sounds a little like extortion. If they're saying I can leverage all these lives that I have and all these people, so do what I want or else give me a kickback. You have to pay. You have to take what I'm giving you.
So they're not just working between the insurance company and the patient. They're also involving the manufacturers as well.
Yeah. So I mean, obviously, I assume you've been to a pharmacy, Mike, at your age, obviously, probably quite often.
He's constantly. He's there. He gets his mail there.
Right. That's awesome. Right. I mean, they pay a price for the medication, right? Mm-hmm. They it comes in a box, and they pay for it. That may have very, very little relationship to what the manufacturer is charging the PBM. because the PBM is now saying on the backside, outside of that kind of distribution chain, we're going to move some group of patients from your competitor to you. And because of that, we're expecting some kind of a rebate.
So it started out sounding like these PBMs were serving a really noble role, finding the best value for people. And it's sounding a lot more complex than that right now.
So do PBMs, do they make a lot of money?
Yeah. I mean,
so they're middlemen, they're negotiating. I guess you've got people there, so you do need to make some sort of money. But I mean, that seems like it'd be one of those, altruistic kind of doing it for the good of people. Oh, I'm talking to a health economist. He doesn't know what good of people mean.
No, it's part of it.
I hear words. Look, now if you talk to them, are they serving a role? They certainly they are, right? They have probably driven a lot more guideline-driven care. I mean, if they would, if you listen to them and you talk to them, and I do, I had drinks with some PBM folks this week, and they only one of them actually had horns, and they were filed down. You could barely see them. They're pharmacists, right? They're trying to maximize the benefit and value of the medications too, and their role is to ultimately get the best value back to the plan sponsor, probably the employer. And
I know from their perspective as well, they also try to put together guidelines for how to use medications because they don't want to see wastage. People going right to the most expensive medication, and people go, well, that's just the insurance company trying to save money. But we know that, Mark, you mentioned clinical benefit. Sometimes there's really not that much difference between an older established drug and, this new really expensive medication that came out. So,
right. I mean, you're talking about a step therapy or a prior authorization, which are in the world of pharmacy can often be, curse words because we feel like it's somebody getting in between the patient and the provider and interfering. Well, sometimes there has to be an adult in the room who says, yeah,
that's me right now.
No, that's a grandparent in the room. That's an older adult.
Great parent. Yeah. Great grandparent. Just conceptually though, like if you just stand back and look at the healthcare system as a whole and how PBMs fit in there, part of me says if they're taking profits out without directly taking care of patients, that kind of looks like, boy, are they really adding that much benefit? So if they're taking out, 0.25%, okay. But if they're taking out, bigger slices of the pie, it's kind of like, yeah, they fit a role, but how much, so.
And so we'll talk maybe about a little bit of that because this whole PBM reform thing, that'll be interesting to talk about. But before we do that, why don't we pause and hear from Mark about the Healthy Minute?
Let's pause for the Healthy Minute, brought to you by the Winery at Young Farms. Today's Healthy Minute is know the air quality index. The quality of the air we breathe has a direct influence on our well-being. The Air Quality Index serves as a valuable tool to gauge the level of pollutants in the air and provides insight into potential health risks. By understanding the AQI, we can make informed decisions to protect ourselves and our loved ones. High levels of pollutants such as particulate matter and ground-level ozone can contribute to respiratory problems, allergies, and other health issues. Monitoring the AQI helps us take necessary precautions, especially on days when air quality is compromised. This might include adjusting outdoor activities, using air purifiers, or wearing masks in certain environments. Several mobile apps and online platforms provide real-time updates on the AQI in specific locations. It's a simple yet effective way to empower ourselves with the knowledge needed to make healthier choices for our daily lives. Prioritize your respiratory health by staying aware of the AQI. Knowledge is the first step towards creating an environment that allows us to breathe easy. That was the Healthy Minute, brought to you by the Winery at Young Farms in Mecosta, Michigan. Please visit www.thewineryatyoungfarms.com for more information. Now, back to the Health Deli.
Boom, chicka boom, healthy. All right, well, thank you, Mark. So before we jump into, PBM reform, as we're talking, we're in healthcare, so we are familiar with, these pharmacy benefit managers and stuff like that. But does the average patient Andrew, I'm looking at you. The leg individual. He's back there stacking bottles and stuff like that, making castles and whatnot. Have you ever heard about a PBM?
No.
So you're totally clueless as to what we're talking about, so you never knew there was some middleman between your insurance company and the pharmacies and stuff like that.
No, not officially. I mean, it's a mystery over there.
Okay.
Every single time my wife makes a phone call about something money related, she seems to get blocked or thrown around.
Okay. So Don, in your experience, or Mark, in your limited experience,
Very
and
limited.
probably not credible experience, do you find that most people outside healthcare have any idea about PBMs?
So I will take this and say, I don't know exactly what PBMs do. And I work in that space now. Most of my career is in hospital pharmacy, and PBMs don't have a large impact there. I don't think. Maybe they do. But in community pharmacy, I will get questions a little bit from patients about, why does it cost this much, or why is this happening? And honestly, I can't answer those questions a lot of times. I don't understand exactly how it all works.
Hence why we had an emphasis on had to have Don show up today.
You're right.
I mean, because if it was up to me, there's no way he would be here right now.
No, I like Don.
Well, thank you, Mark.
Yeah, because you guys are both,
It's finally a nice Klepser. Except your mom.
Yeah,
That's true.
I'm stammering here because I don't ever think I've heard, nice and being referenced to Don in the same month, not let alone same breath. Anyway, most people don't know about PBMs. Is that, kind of what and again, I'm in the same boat as Mark. It used to be just this, I'd hear it, I know they're there, no idea what they did. And now all of a sudden it's this, we need PBM reform and stuff like that. Do you feel like most people have any idea what's going on? And then what can you talk about this PBM reform stuff? What is all that supposed to do?
So you're absolutely right. I mean, PBMs, most people, you say, hey, who's your insurance with? Right. And they'll say, whoever their major
Blue Cross
medical,
or
Blue
whatever,
Cross, yeah. And with probably no recognition that, in fact, their pharmacy benefit may be a completely separate company, right?
It's like the entity that shall not be named.
Yeah,
it's like Voldemort.
Actually, that's the best PBM.
Really?
Yeah, they're really good.
Avacadabra or whatever.
I don't even know
trying
what
to
reference
remember.
you're trying to use.
Trying to
right
remember
now.
one of these lethal curses.
Yeah. But I mean, to your point, like no one in the public is complaining about a PBM unless they have to call and interact with the PBM, which doesn't happen very often because mostly that's the community pharmacist.
Right, they're going to be interacting with that.
And so, if you think about who's clamoring for PBM reform, it's pharmacy. It's not the public. It's not insurance companies. It's not employers. It's the pharmacy who's being squeezed by the PBM, right? The PBM is taking money back from the pharmacy in effect. So, I mean, the role they play is to be under the radar, right? To provide a service, to be unknown, but they have an outsized influence given kind of what people know about them. And
so their money is made, essentially, if I get this right, and I'm asking, not making a statement, is by carving out some of the community pharmacy's profit and some of the manufacturer's profit.
Yes. I mean, historically, the idea would really be more of a transaction fee, right? You are providing a transactional service, you are processing claims, and so they would take some piece of that. More recently, and I think Mike getting to this idea of PBM reform, they're taking a little bite on both sides, right? They're negotiating a lower price at the pharmacy, and then they're negotiating a different price, and there's a spread there, right? So what they are paying ultimately to the manufacturer, what kind of kickback, and they're keeping some of that difference or all of that difference, and not passing it on either to the pharmacy or to the patient.
Okay.
And so when people say, well, what role they're playing and why are they doing that? Well, that's how they are able to operate.
So they're a little bit more like a salesman in a sense. So like if you were a traditional salesman and you went to a big department store and you were selling neckties, right? and you went to the department store and said, hey, these are the best neckties. Use these neckties. And then that salesman would get a little rebate from a little incentive from the necktie manufacturer. So every necktie that was sold to that department store, they get a little piece of that. Is that a little bit like a PBM? So if a PBM can sell drug A, every time that pharmacy buys drug A, the PBM's getting a little bit of money from that drug manufacturer.
Well, I mean, to take the necktie analogy a little further, I mean, right? The difference is what you're saying is not only am I going to sell more, neckties, but I'm going to take sales away from Mike's necktie company, right?
Right.
And so I'm going to move this market because all of these people are my members, are my clients, are my customers. They're only going to wear blue neckties.
Gotcha.
Right? So blue necktie guy, you're going to make way more money. So you're willing to sell at a lower price. I'm going to move market for you.
All right. I'm still spinning here, so I'm going to just move things along before my head explodes, because I heard that, some groups were revolutionizing drug pricing and everything was going to change. CVS announced something they were doing. Mark Cuban's got some company, and, they say, we're going to save people as much as 60%, and stuff. What are all these things? Do you have any idea?
Yes. Scams isn't the word I want to use, right? I think you can go in and look in the case of Mark Cuban and what he's trying to do, it gets to transparency. And I think we'd all agree transparency is a good thing, right? It will help and
except in pants. I don't want to see Mark in transparent pants.
I'm going to try and move through that. I can't get that out of my head right now.
Next episode, folks.
Right. So it is, if we can have transparency and people know what the price is, they will make better decisions.
Okay.
But when you hear about as much as 60% off, it's a little bit, think infomercial, or, we can save you up to, and it's on one drug, one product, one generic.
Got it.
It's not across the book of business. It's not across all drugs.
Okay. So it's not all what it appears to be. It's a good show.
It's a good show, and there's probably some benefit. I mean, again, it's smart people trying. One of you is a smart person,
right,
Mark?
Sure.
And even you are struggling to understand. It's really difficult.
Very complex system.
Anybody who comes in, whether it's Amazon or Mark Cuban or any other outsider who comes in and thinks, well, this should be really easy to fix. It's not, right? There are a lot of vested interests. You get into it and you find out. I mean, even what CVS announced, I don't know, in the past couple of weeks, again, sounds right. It sounds like moving towards transparency, but it's going to take 3 years. And, again, it's probably as much about getting out in front of and avoiding criticism as actually doing anything.
Okay.
That you're probably, the end user, the customer, the patient is probably never going to see.
So it's more hype than substance at this point in time.
I think so.
Okay. So let's move on with this, because I think that Mark's head is hurting. He's already thought more today already than he's thought in the past 25 years.
I know.
You mentioned drug shortages, and I just wanted to touch on that because, like I mentioned, when I first started, in pharmacy and in healthcare, you never heard about drug shortages.
Never.
It just didn't occur.
Even when I started, like 40 years after you. You still didn't
140
hear about
years
it.
after me, yeah. And so I was looking at the FDA's website, and it said that there are currently 143 medications listed on the short supply list. And they were happy about that because this was down from more than 300 medications, last spring. And these aren't crazy medications. These are things like sterile water, penicillin, water pills like Lasix, albuterol that people use for respiratory condition. They're not new medications. So these are things that people rely on. How can they be in short supply? Do you have any insight of what the heck is going on?
So if we take it way back, I think, Mark, you asked the question about if we change things, would innovation go away? I mean, in some ways, this is a reflection of, these are all, Mike, to your point, these are all older drugs. These are all generic drugs. These are all cheaper drugs.
Inexpensive, right?
Inexpensive, right? So the profit margin is not very high. So, I think everybody assumes, oh, it's a generic. There are 20 companies making this. Well, oftentimes it ends up being one or two. And guess what? They're probably not in the United States. And so all of a sudden now you are subject to global distribution channels. And if one company, one manufacturing plant has a shutdown or a strike or a whatever supply disruption, it affects the entire chain. And so,
well, and to your point, I mean, when you say a drug, it's not like these things are out there in a powder form, pre-made, and we just have to like make it into a tablet. There's components that go into each of these medications. There's different chemicals, and these are not always made by the company who's manufacturing the medication. So they have to buy them from other places. And to your point, people are always looking for the cheapest ingredients to keep their costs down, to make the cheapest medications. And those type of things, where those chemicals come from and stuff like that, I heard you really don't even have to track that at this point in time.
Really?
Yeah.
That's scary.
It is. And, so Don, have you heard about this transparency in medicine's supply chain? The stuff that's going forward where they're trying to make manufacturers say who they're reliable, if they have reliable sources, because some of these, chemical people that they're getting their stuff from, they're here because you're doing it in your garage and, man, or something like that. And then the next day, you get eaten by a gorilla or something like that, and so you're no longer doing it. And
there are so many things wrong with that last sentence. There's a bleep button that'll be edited out,
yeah.
right?
Yeah.
Yes, I've heard of, and that, again, that sounds great, right? That actually makes intuitive sense. But you know what else that does? It raises cost. It raises prices, right? I mean, anytime you add another, we've just spent the last 15 minutes talking about a third party, an intermediary, somebody else in the system. That's exactly what you would do. You would add somebody else who's going to serve that role, and it's an added cost. It's an added.
Do you think like lean management practices have contributed to? I mean, it's all I hear about in management is lean. I don't necessarily want a drug supply that is really lean. As you manage pharmacies, pharmacies generally get an order every single day. So really you want to keep an inventory of literally 1 day supply. So if there is any hiccup in the supply chain, you don't have a month's supply there. You don't have a cupboard that you can go to. You don't have a freezer full of bacon like we do here at the deli. You have 1 day or 2 days, and hospitals, maybe a week if they're lucky. So it's just, I don't know. Is it too lean, do you think? I don't know.
Possibly, yes. And again, right, you keep the same 1 day supply, whether that's a $10,000 drug or a 10-cent drug, right? I mean, and it's really, you're not seeing shortages of the $10,000 drugs. It all comes down, this is an economics thing, right? If you're a manufacturer, what are you spending your time manufacturing? If you're keeping it, the supply, or stocked, you want to be lean. You want to keep your inventory costs down because you don't know what's going to happen. And we have the perfect outcome for the system we have, right? I mean, it is.
So you predict that this would have happened based the way we're managing stuff.
Absolutely. I mean, if you think about, so we've talked a lot about drug prices, and generally we talk about brand name products and the expensive ones. But to your original question, the market for generics is much more akin to classic economic theory. More suppliers, more buyers, right? Price goes down. Well, at some point, it goes down to a point where it doesn't make sense for us to manufacture it.
And that was Pharma Bro kind of thing. He would see things that were, essentially dirt cheap.
Single source.
But people needed those. Yep. And so he would buy them, say, all right, now that I've got what you need, so I'm holding it. I know you need it. I can charge what the market's going to, dictate.
And theoretically, there's no reason another manufacturer couldn't start manufacturing that. But that process, the application process, the inspection, that takes a long time.
And
so
it's
meantime,
costly.
Very costly. So in the meantime, you could carve out huge profit and really not do anything theoretically
and so
illegal.
Even though this, from an economic standpoint, was smart business, the dude got crucified because people were running short of the medications. They can't believe one day they were charged 10 cents and now they're charged $50, for something.
And I don't know the ins and outs of that story, but he did go to prison over it, right? I mean,
yeah, like most, economists and
Eventually,
stuff should.
yeah.
that's how it.
It's a matter of when, not if.
Yeah.
Right.
Well, Andrew, before we wrap this up, you've been sitting over there quietly stacking. Do you have any questions for the health economist in the room?
I don't at this time.
Thanks for all your contributions.
After talking about video at the beginning of the show, I had some technical issues, so I've been dealing with that. It's fine. We're going to have an episode, but for about 2 minutes, we're going to have a technical difficulty screen come up. It'll be great.
Is
That's
that
okay.
Is that where I'm? Are we able to
We're
say
primarily audio anyway, right?
Mike was swearing during this time? Yeah.
Don broke the camera.
Don. Yeah, he does it a lot.
No.
All right. So as we wrap, and I hate to say this, but I mean, this was a great conversation. You don't know how much that pains me to say that. And we actually might have to have him back.
I agree.
At some point.
I'm maybe saying not just have him back, maybe replace you with him.
I want my own podcast.
Upgrade. I got you.
So
This is Mike 2.0, the new and improved Mike.
I like
Don.
the fact that he has to live with that, kind of like Van Halen when they replaced David Lee Roth. That Sammy Hagar still had to sing, David Lee Roth songs. So there you go, living in my shadow. But I was thinking maybe we could have a annual episode about Ask the Health Economist, and maybe we can actually find a good one.
Actually, I don't want to tell you that's a good idea, but that was a great idea, Don, to have that.
Mark, thanks. No, we workshopped it.
Yeah.
Actually, it was a
Good.
joint.
Good.
My idea. All right. So with that, I'm going to get rid of these two yahoos, throw them out, so Andrew and I can go hang and pretend we're friends. And so, hey, until next time, hang up the sign. Let's go out and
time for break.
Enjoy our coffee mugs.
Thanks for stopping by the Health Deli to sample some of our wares. We're open 24/7 on Facebook and Twitter at The Health Deli, or visit thehealthdeli.com to send us a question or find any of our locations. Please come again. We will be regularly stocking the shelves with fresh content and new wellness specials. As always, we want to give a special thank you to Andrew Tingley and the crew at Ferris State University's Television and Digital Media Production Program. Until next time, so long from the Health Deli, where the topics are tasty, the takes are fresh, and the discussion is free.